Good morning, guys. Today we're talking about nerve injuries. Nerve injuries, Wallerian degeneration, classification of nerve injuries, and something called tunnel sign. Alright, let's go ahead. So, coming to the introduction, peripheral nerves are an important connection between the CNS and the peripheral body. And unlike the CNS, the peripheral nerves have the ability to regenerate, which is what this lecture is going to be all about. Alright. So the peripheral nervous system is part of the nervous system which includes the nerves and ganglions outside the brain and spinal cord. And they consist of 43 pairs of cerebrospinal nerves and sympathetic nerves. So what is the structure of a peripheral nerve? We all know this diagram which we have seen since our high school or 11th and 12th grade, which is the nerve consists of two parts, an axon and a cell body. And the cell body gives off certain dendrites, which the dendrites attached to the axon terminals. Sorry, not attached, they form a connection. So a ganglion is nothing but a group of cell bodies, and the nerve fibers, the strands of nerves that we see running across, are nothing but groups of axons, just to be clear. And a small bundle of such nerve fibers enclosed in a sheath is called a funiculus or a fasciculus. So depending on the number of fascicles present, they can be monofascicular, oligofascicular, or polyfascicular. So there's only a single fascicule, usually a few fascicles up to 2 to 3, and polyfascicular is multiple fascicles. And these fasciculi are bound together in a common membranous investment or sheath of the whole nerve called the epineurium. So what is the epineurium? The epineurium is the outermost dense connective tissue covering the entire nerve, and it makes up the fibrous, it's a fibrous coat. Also, the epineurium has two parts, the outer fibrous coat and the inner loose connective tissue between the fascicles of nerve fibers. Okay, and so the outer fibrous coat and the inner loose connective tissue between the fascicles of nerve fibers. And the epineurium is an analog of the dura mater of the CNS, and damage to the epineurium usually does not hamper physiological nerve conduction. We'll talk more about this later. Perineurium has several layers, about 1 to 15 of flattened epithelial cells, and it is the dense connective tissue covering one fascicle. So epineurium is the thing covering all the fascicles, the common fibrous coat, and also the loose connective tissue between fascicles. The connective tissue covering each fascicle itself is called the perineurium, and any damage to perineurium is not compatible with nerve conduction. So it provides the necessary milieu inside the nerves to conduct impulses. So perineurium confers structural protection against penetration and crushing injury, and it is dense where the nerve crosses the joint and provides a greater need for mechanical strength, and is also thickened at nerve bifurcations and branches. So as you can imagine, when a nerve crosses a joint, it is prone to more stretching and compressive forces because the joint will undergo a range of motion during flexion extension. So the nerve tends to be thicker at this point due to the perineurium, which helps provide it some robustness against damage. It represents an analog of arachnoid membrane of the CNS. Coming to the last and final layer, the endoneurium. So in these fascicles, you can see each axon running. So each axon is surrounded by something called a endoneurium. So you can see the outer layer is the perineurium, and endoneurium is the thing which covers each of the axons and also the loose connective tissue between the axons under the perineurium. And this endoneurium forms a blood nerve barrier. So the endoneurium resists elongation or stretch injury also. Coming to the general anatomy of the nerve, you can see the axon is surrounded by myelin sheath, and this is the orange structure. And there are certain areas where the myelin sheath is absent. These are called nodes. and the edges of the axons which are surrounded by myelin sheath are called internodes. So this is an internode and this is a node, and this entire structure is enclosed by a neural lemma. So you can see the myelin is disrupted, but the neural lemma is continuous, which is the blue structure. Okay, so unmyelinated or sparsely myelinated fibers, several axons are wrapped by a single Schwann cell. You can see one Schwann cell for several axons. Whereas in heavily myelinated fibers, one Schwann cell is present for each axon. So why? Because the Schwann cell provides the myelin necessary for the myelination of the axon. So the portion of the nerve between two nodes is called an internode, like I said, and this is called a node. So very important, fascicle organization in a nerve. So as we imagine like these nerve fibers as electrical cables running, but this is not so simple. In fact, the axons are arranged in something called a plexiform arrangement. So what this means is that the rail structure is quite different from the cable structure we envisage in our minds. Why? Because we don't imagine the electrical cables interconnecting with each other and going through, but that is actually what happens here. So as we move from proximal to distally, so proximally is when the plexiform arrangement is more predominant. As we come to the middle region, we can see the plexiform arrangement is less, and distally we can see they're just like regular electrical cables which are running parallel to each other, and there's less intercrossing of the axons between each fascicle. So how it actually looks is like this. So you can see one axon from here will go to this fascicle, one axon from here might cross over to this fascicle, and that's what I mean by plexiform arrangement. But as you can see distally, the plexiform arrangement is less and the nerve fibers are more like cables. So biomechanical properties of peripheral nerve. So the nerve has a limited capacity to elongate or change its length. Up to 8% is tolerated by the nerve. More than 8% will lead to traction injury of the nerve, and if persistent will result in stretch injury, and more than 15% elongation or extreme stretch results in axonal disruption. So 8 to 15% the nerve can tolerate for some time, but more than 15% it leads to axonal disruption. Also, the nerve has the capacity to slide or glide related to the interference tissue, relative to the surrounding tissue. So I'll just show you a video to demonstrate this. So as you can see, when the joint flexes, the nerve glides. It doesn't stretch, it glides. You can see these two red balls coming together. Yeah, so this is the ability of the nerve to glide. And it also has the ability to tolerate increases in pressure. So pressures more than 60 mm Hg cause complete blockade of conduction. But the nerves can generally tolerate pressures of up to 30 degrees, 30 millimeters of mercury. Greater than 30 millimeters of mercury usually cause paresthesia and neuropraxia. So more than the pressure, the duration of the pressure is important. For about 15 minutes, it produces numbness and tingling, while sensations begin to reduce after about 30 minutes. So the nerves are injured in various methodologies: stretching, ischemia, compression, lacerations, or even during burns. So coming to the process of Wallerian degeneration. It was named after Augustus Volney Waller and is also seen in the CNS, but mostly occurs in the peripheral nerves. So I'll explain the process of Wallerian degeneration. So imagine a nerve injury occurs at this level. First, we'll talk about what happens in the proximal segment, which is this, and then we'll talk about what happens in the distal segment. In the proximal segment, three things happen. The nucleus migrates to the periphery. There is swelling of the cell body, and the nucleus begins to produce mRNA. The mRNA produced goes to the nacelle granules, which are nothing but rough endoplasmic reticulum, and this produces proteins, and these proteins are packaged then sent down to the thing. So these proteins are basically to help with a repair of the nerve. So this was happening in the proximal segment. And also what happens is, since the nerve is injured here, the most proximal node, internode, gets degenerated. So as you can see here, this gets degenerated and only one node is here compared to here. So there's degeneration of this area and the swelling of the cell, and nucleus migrates to the periphery. Now we'll talk about what happens in the distal segment. In the distal segment, there's complete disruption of the axons and the myelin, and you can see the axons and myelin are completely degenerated, and these blue cells are nothing but Schwann cells. And why endoneurium is important is because the endoneurium produces 5-hydroxytryptamine and histamines. What this does is this attracts macrophages. Macrophages come and eat up all these remaining axonal and the myelin sheath debris, and this is what gives space for the proximal stump to give axonal sprouts, which migrate down this and attach to the distal nerve. So as you can see, a combination of proximal segment change and the distal segment change is what we call Wallerian degeneration. So once the axonal and myelin debris is cleared out, the proximal segment begins to sprout axons, and these go towards the distal segment and then they attach here. So these Schwann cells aid in the process of helping formation of axonal sprouts as well, and also guiding the axonal sprouts to the distal segment. Here you can also see they form something called Bugner bands, which guide the proliferating axons to the distal stump. They also give growth factors and trophic factors which help guide the nerve. So yeah, about 70 to 96 hours after the nerve is injured, the myelin lamellae are disrupted into small fragments called myelin ovoids. And within 96 hours, the Schwann cells synthesize growth factors so that axonal sprouts can come. And by day 7, the macrophages, I told you the endoneurium releases 5-hydroxytryptamine, so the macrophages are attracted to this area and they clear away all this fragmented myelin and the axonal debris. So all axonal sprouts which are formed initially are unmyelinated, whether they arise from a myelinated or unmyelinated fiber. Coming to the classification of nerve injury, initially Seddon classified nerve injuries as neuropraxia, axonotemesis, and neurotemesis. But because of the variability in the injuries, Sunderland came and modified Seddon's classification into 6 types. First is neuropraxia or Sunderland 1. This is a local conduction block with variable myelin damage. However, axons are continuous. So basically it's divided into 6 types. Axonotemesis is divided into 2, 3 and 4, and neurotemesis is 5 and 6. I will show you each with diagrams. Before that, we'll discuss something called a Tinel sign. Tinel sign is nothing but paresthesia experienced along the nerve distribution on gentle percussion from distal to proximal over the nerve. So what this means is, if we come percussing from distal to proximally, there is paresthesia produced due to bare, young, hyperexcitable unmyelinated sprouts from the injured proximal end. So why we come distally to proximal is, we know that the nerve regenerates from proximal to distally. So if the paresthesia experienced more distally, means the nerve is regenerated and almost reached the end. Whereas if paresthesia is present only proximally, it means the nerve has just started to regenerate. So it is a relied sign in clinical practice and done for almost any nerve that has sensory fibers. So how do we interpret this? So if the Tinel sign is non-progressing, it indicates interruption of nerve regeneration. It is a static Tinel sign. What they mean by non-progressing is, as we progress from distally to proximal, as time goes on, we expect the paresthesia to be elicited more distally. Whereas if it only stays proximally and doesn't ever progress distally, with even though a good amount of time passes, it indicates the nerve degeneration is stuck. Whereas an advancing Tinel sign is seen when the nerve is regenerating well from proximal to distally, and even distally also we can feel the paresthesia. This is seen on grades 2 and 3 only. I'll talk about this again. So no estimate of motor recovery should be made from Tinel sign, as it indicates sensory recovery only from sensory sprouts, not motor sprouts. Okay, grade 1 somnolence or neuropraxia. There's no disruption of any of the layers of the nerve. There's only a variable amount of myelin damage. You can see the small chips in myelin. That's the only thing. And there's a localized conduction block. It is a physiological disruption with near anatomical preservation. Very important. Tinel sign is absent as the nerve is not even injured. The nerve is injured, but anatomically it's almost intact. Only small bits of the axon are demyelinated, and there's usually loss of function is often complete and usually recovers within 3 to 6 weeks, up to a maximum of 3 months. A characteristic of neuropraxia is simultaneous return of motor function in proximal and distal musculature. This doesn't occur in Wallerian degeneration. Why? There's something called motor march phenomenon. So as the reinnervation of the injured nerve proceeds, the muscles nearest to the site of injury recovers first, followed by the distal ones. Why? What does this mean? So imagine there's a radial nerve injury in the radial groove of the shaft of the humerus. The first muscle that will recover would be the brachioradialis, because it is innervated first, and then slightly more distally the radial nerve innervates the ECRL. So as the radial nerve regenerates, what happens is the muscle more proximally gets reinnervation first, so which is the brachioradialis, and then the ECRL, and then the nerves further down, and then the muscles further down, excuse me. So this is what they mean by motor march. Whereas in a neuropraxia, there will be simultaneous return of motor function of all proximal and distal musculature. Grade 2 or axonodemesis is when the orange is the axon. So the axon is also disrupted and the myelin is also disrupted. However, the yellow structure you see here is the endoneurium. The endoneurium is intact. Tinel sign will be positive, as axonal regeneration will occur with the motor march phenomenon. So recovery is usually complete. Key point is recovery is usually complete. Grade 3 somnolence is when axon is disrupted and the yellow structure you see as endoneurium is also disrupted. So what happens is the endoneurium does heal, but however sometimes the scar tissue within the endoneurium can obstruct the tubes, and the axonal sprouts path to the distal stump is not so direct, and also the nerves can escape through the endoneurium into the surrounding nerve, and it can innervate, cross innervations can occur. So what happens is the returning motor function is evident from proximal to distal, but with varying degrees of motor and sensory deficit. Complete return of neural function may occur, but it usually does not occur, and this yields the most variable clinical recovery. Grade 4 somnolence is when the disruption of myelin sheath, axon, endoneurium, and the brown structure, which is the perineurium. The nerve, there will be a lot of scarring, and the nerve continuity is usually maintained only by scar tissue. So if scar tissue is there, the proximal axonal sprouts cannot reach the distal area. Prognosis is very poor, and useful function is only got back with surgery. Grade 5 is when there's complete transaction of the nerve, including the endoneurium, perineurium, and the epineurium. So no spontaneous recovery is expected without surgical intervention. So as you can see here, tinel sign is absent in Sentinel 1 or neuropraxia. I told you why, because there's only myelin disruption. There's no nerve injury. There's no axonal disruption as such. Tinel sign is present and progressive. Advancing tinels is seen in 2 and 3 because the nerve regenerates and it goes from the proximal stump to the distal stump. So it is an advancing tinel sign which is seen. Whereas in grades 4 and 5, a lot of fibrous tissue is formed, so the axonal sprouts are formed in the proximal stump, but it is a static tinel sign and they do not progress front. So this indicates poor prognosis. So recovery potential in 1 and 2 Sunderlands is full. 3 is usually slow, complete, but very rarely, but mostly incomplete. 4 and 5, the recovery is almost nil. And yeah, so the only way they will recover nerve function in 4 and 5 is nerve repair, graft, or transfer. So why the endoneurium being intact is important is because the neurolemma of axons, the outermost layer, does not degenerate and remains as a hollow tube. As the axon sprout reaches the tube, it grows and advances at 1 mm per day. And the endoneurium provides a tube or a pathway for the regenerating axons to follow to the distal axons which innervate the muscles of the skin. So as you can see, if the endoneurium is disrupted, what happens is the axonal sprouts can go out and innervate with some other axonal sprouts, and or they might not innervate anything at all. So this is why it's important for the endoneurium to be intact. So axons degenerate by neurotropic substances within distal nerve tissue. So if the endoneurium is intact and the distal nerve tissue produces these trophic substances, the axonal sprouts will reach the distal stump and it will lead to full regeneration. So the main role of Schwann cells is to provide a supportive substrate and growth factors for regenerative axons, forming something called Bungner bands, and also produce trophic factors and guide the axonal sprouts from proximal stump to the distal stump. This is the role of Schwann cells. Alright, that will be everything for today. Thank you.